Good morning.
Moderator today, and John, it's all yours. Thank you, everybody.
Thanks, Richard. And those of us old enough to remember Ed Sullivan, we have a really great show today. So please stay with us. You will learn a lot. And I will kick it right off. And what I'm going to do is quickly introduce the panelists, and then we'll get right into the discussion. So I'm going to go in the order I have them here on my sheet of paper. So first we have Wynn Brown, who's the president and CEO of Haywood Healthcare. We have Pat Jordan. Hey, Pat, haven't seen you for a while.
Hey, John.
COO of Dartmouth Hitchcock Health. We have Richard Weiner, MD, who's the president of Winchester Hospital, part of the B.I. Leahy Health System. We have Peter Healy. Is Peter here? I don't see him. Well, if he's not on, he'll be joining us. Peter Healy, who's the president of B.I. Deaconess Medical Center, part of the B.I. Leahy Health System. We have Errol Norwitz, MD, who is president and CEO of Newton Wellesley Hospital, which is part of the Mass General Brigham network. And then we have three consultants, Paul Conrad, who's director of engineering at Canon Design, Scott Latimer, who's the healthcare sector leader for Gensler, and Andrew Brumbeck, who's the healthcare studio leader with Smith Group. This is going to be a conversation, and I'm not going to call on anybody in particular, although I may if nobody speaks up. And the general question, and we'll see where this goes in terms of the conversation, but the general question is, if pandemics are here to stay, there's been significant learning over the past 18 to 24 months. What would be the three most important considerations you would make as you design flexibility in uncertain times? And we're thinking in terms of either physical renovations or a new hospital. And I would think most of the learnings come from operational issues that you've had to face and ways in which the facility either supported or prevented you from operating in the way and with the flexibility that you would need to through a pandemic. So anybody want to step into the void first? Go ahead, Pat.
John, can you guys hear me?
I can hear you. I know you're in Vermont. You may need to speak a little louder.
Well, this has been an interesting time for us up in Dartmouth. About 3 months before the pandemic hit us, we had approval from our board to build a new tower here in Lebanon at the Academic Medical Center. 155 million, two floors with 64 beds, and then some shelved floors with 64 beds. And I think the first decision we made as the first patient in New England, which was one of our residents, was we said, we're going to put this on hold. And, as we learned more about 3 months later, I think in June, we got together and said, this is crazy. We're going to do this building, and we're going to start doing it. So, I think some of the things that we learned during that first critical phase of the pandemic influenced later some of the design of the new tower that we're building. And this is probably not a surprise to any of you, but really looking at making rooms universal so that they could be used for any level of care. So that, it could be med surg, or we could quickly make them ICU if necessary. Obviously, a lot of work early on, understanding with the HVAC system so that we could have maximum flexibility. And that's been important. One of the interesting things that our team did was really focused on support staff spacing in the inpatient units. So with the concern of lack of staffing that we had back even then, before the Great Resignation, with folks that were out on exposed to COVID, they really worked at building bigger support spaces in the inpatient areas, recognizing that that having just-in-time logistics might be a little more difficult. So that's stuff. And by the way, I must give credit to Dave Duncan, our great vice president of facilities, who told me what we did, because I certainly had no knowledge of all the work that he was doing. So we've got a great guy in Dave Duncan up there, and he's just done an amazing job. So that's some of the lessons that we learned, John, that we're putting into practice as we build this new tower.
And I thank you, Pat. And a follow-up question, if you have the answer, perhaps Dave does. Did you need to increase the amount of space in your building to accommodate this additional flexibility?
I think we changed some of the design, but the footprint is the footprint, John. It was going pretty big, anyways.
Yeah. Okay.
Dave, feel free to comment if I got that wrong.
No, you got it right, Pat.
Thanks, Dave. Rick?
Thanks. Pat, could you build me a tower, please?
Hey, Rick, as part of our strategic plan, we're planning on acquiring hospitals as far down as Reading in that area. So we'll be talking soon.
Okay. Just a few additions. I would have ideally every med-surg room, every floor bed have negative pressure capability, because you never know how many you're going to need and where you're going to need them. Of course, the operating rooms are usually positive pressure for different reasons. I would be prepared to burn through a lot of cash when all your elective work is eliminated. But I would have conference rooms that not only are designed to be eating space, but also really set up well to be able to have virtual meetings, so that people that are on the other end can actually hear people in the room talking if they're not right next to the microphone or one of 3 or 4 microphones. Sometimes they have them hanging from the ceiling a little bit, or I'm sure that there are great ways to do it, but I think virtual meetings are here to stay, either intermittently or continuously. And then I would make sure that the entrances are adequate, sometimes for bidirectional traffic that could be separated, but have enough room for screeners, have enough room for PPE, really to be set up to anticipate the screening process being different. That's it.
Thanks, Rick.
Yep.
I just had one follow-up. Were you able to move some of your electives to an outpatient setting?
Yes, we have an ambulatory surgery center around the corner for ORs there, and we did shift as much of the same-day surgery over there as possible.
Yeah, sort of percentage-wise, what order of magnitude, what that might represent?
Yeah, I would say probably 75% of our elective work was shifted down there. We already had, a large amount of it, but an additional 75%.
Mm-hmm. Great, thank you. Any other observations? Yeah, Wynn.
So we are working with HED and Colliers to build a new surgical pavilion, which also gives us a new secondary entrance, an outpatient entrance, which I think will be our primary entrance. And we spent a lot of time talking about the flow from drop off to registration and into the facility, and also keeping in mind that when we surge again, we need to think about the fact that a lot of people are going to be coming in alone, and then how do we manage that flow and throughput when you can't have caregivers with you. So, and already hit on the unidirectional, just thinking about how we flow through the facility. The trouble is when you go third or fourth, everybody's hit your great ideas, but we're really paying attention to that. The other piece is that really came up for us is respite space for our caregivers. When it comes time to them needing a break and you can only have one person in a break room, your conference rooms are being used for other purposes, trying to figure out how we support our staff so that they get the space that they need to eat, to take a break, to recharge. And that has been a huge challenge for us in a legacy facility. So we're taking a look at that, especially on the surgical side with our break space that we're creating right now. So those are just a couple additional comments.
Thank you, Wynn. Any other observations? I had a question about triage, how you each manage triage of incoming patients and how you handle testing. You know, did you put up a tent out front? Did you have space inside the front door? Did you send them around the back door? What did or you just told them not to come here at all and go somewhere else? So how did you each deal with that? And how, you know, looking forward again, is there a built way to deal with this issue, or is this just solely operational and a temporary type of facility like it's in? Anybody want to tackle that?
I can start. I think it's in
Okay.
all of the above, depending on your region. You
Yeah.
know, we had offsite testing for the community. We had testing on campus. We had testing at our urgent cares. We had an offsite on our campus as well. I mean, part of it was trying to keep people from coming into the hospital for their testing,
Yeah.
because you know, our entries were already struggling with screening and all the things that we weren't designed to do. We actually are looking at making, we have a, you know, a lot of us have big like ER lobbies. In our big ER lobby, we just have a proposal right now to actually put semi-permanent structures in with negative pressure for arrival and screening of potentially COVID positive patients or other infectious diseases, so that we can try to manage our core a little bit better. Also trying to figure out how to deal with the behavioral health side of things, which is an ongoing struggle.
Yeah.
So trying to keep it from the getting to the hospital if it's appropriate to go someplace else first.
Yeah, John, I'll jump in. I think this is a good example of how our thinking has evolved over the last 24 months. You know, we've gone through 3 waves of the pandemic over the past 2 years, and our thinking has matured over time. We started out in an emergency situation, standing up, you know, a tent outside the hospital. We had people in full PPE because we didn't know how the infection was spread. The testing wasn't very sophisticated. And I think that's really evolved now as the testing has got better, as we understand more about the epidemiology of the disease. And it's becoming, and it's becoming much more sophisticated. So, you know, we've learned a lot, but, you know, faced with a different disease, we may have to go through the same evolution. But it's definitely been a progression over each of the 3 waves of the pandemic.
So, Errol, so there's no sort of permanent modifications you're proposing at Newton Wellesley based on what you've learned the past couple of years?
You know, I think we managed the situation very well, given
Yeah.
what it is we were dealing with. And there are definitely lessons learned that we might do differently. But overall, I think, you know, we would have probably gone through the same steps and probably will in the future, because at the beginning, there was just so little information. We had to be cautious. And as we've learned more about the disease, and the testing has gotten, you know, much better, and the turnaround time is much quicker, and we know how to take the tests. I think we pivoted very quickly, as did everybody.
So related to I'm not speaking just to you nor Errol, but related to this, sort of how might we deal with surges of patients in the future? I mean, it's perhaps not unlike. Well, I don't want to begin to answer it. I'm looking to you to answer it. You know, we've had waves of COVID, right? And how do you manage those waves? And again, it sounds like it's being managed even before the patients get to the front door of the hospital, right? So I know inside MGB, it was always, at least in the 3rd wave, it was call before you do anything. Call in and we'll tell you, we'll give you directions. But, you know, that doesn't work for everybody. Some folks just are going to show up no matter what. So how did you deal with these waves of, or these surges? And what were the implications on your regular patients as well, inpatients?
Hey, John, for me, the easy answer is we haven't, especially in that first wave. And some of that was regulatory and the unknown. But, we stopped serving, elective patients. And in fact, we've done that since August this year with the lack of staffing. And, it's interesting as you talk to the public and all of our friends, they'll say, oh my God, I was reading the paper and you guys are at 90% capacity. And I'm like, they don't understand that if you're not at 85, 90% capacity, you're losing money. And I don't think the payment systems are going to change to allow us to build more capacity in the event of this in the future. And so that's a real struggle. I think it's worth a national debate.
We're starting it right here, Patrick. Yeah, Rip?
Yeah, I wonder if along those lines, which I 100% agree with, it's really making more of your non-patient care space patient care capable, whether it's having gases and things in the walls and identifiable places, but really to have a lot of your space that you would routinely not use for patient care in a place with the ability to do that. I think that's the only way you could have that kind of flexibility, because Pat's absolutely right. You can't have standby capacity. It would be a killer. Plus, we're so space constrained, we can't have it anyway.
Yeah, I've heard that that's one of the responses now that hospitals are increasingly looking at is setting up some sort of infrastructure in their non-patient spaces to accommodate these surges. And everything from corridors to conference rooms to other spaces which are appropriate in those buildings. Scott, let me call on you. What are you seeing sort of from a perspective of somebody who visits a lot of hospitals around the country?
John, just excuse me, it's Richard, just for a second. Pete Healy's on with us as
hi,
well.
Peter.
Yes, I'm very sorry. I had a little issue here, but
No
sorry.
problem. No problem. Feel free to jump in anytime. It's just a round robin discussion.
Okay.
Scott.
Sure. Thanks, John. I think the things that have really struck us and to that, but by the way, to that list that was just being put out about, kind of putting things into other spaces. I think there's a lot of promise with parking structures. And if anybody's looked at Rambam Hospital in Tel Aviv and what they've done with their underground parking and the ability to kind of, because of security concerns, being able to move, care underground, whether or not you go underground, there is an opportunity, I think there, and we did some modeling of that. I think there are really three big things that on a bigger trend basis. One is this physical digital convergence and, beyond telehealth, the ability to really be, to really manage hospital at home for pretty acute medical patients. I've seen some systems doing that. And of course, that then enables them to create capacity at the hospital for a surge. It's not easy and it's not cheap, but the organization I was talking with, they believes that at a certain scale, it's going to at least be break even. And again, it's an less expensive from a capital standpoint way to create capacity. The other big thing that we haven't talked about yet is really, some of the other disruptions, particularly supply chain. And so how we've acquired supplies and so forth. I mean, the lesson is, has been to, source more locally to the extent possible. And I think there's going to be a spin-off benefit of us being able to, kind of manage the sustainability and the carbon footprint of organizations as we look to more local sourcing. And then the third, and Wynn mentioned this, but workforce, with the competition for talent that is going on, environment matters, and environment that people work in, both the, kind of creating the respite, but also just being kind of competitive and being able to offer, again, an organization that talks about their two objectives coming out of the pandemic are hope and joy, hope for patients and joy for staff, and really when you think about it in that term, kind of how you enable a staff experience that creates joy in the work they do, and particularly with all the stress that staff have been under, kind of beyond the better break room really is kind of goes into every environment. And again, there are a lot of promise in kind of the digital space. And so that convergence that's really accelerated by this pandemic of how we use various technologies to manage clinical as well as the administrative aspects of care.
Thanks, Scott. Other than the, I think everybody saw a bump in telemedicine, and some of us were better able to accommodate that than others. But have you seen the adoption of any other technology? We've talked about video conferencing, of course, so we don't need to go there. But anything else that may not be on top of the horizon?
Yeah, when you look
next, right? Yeah.
when you look in the startup world, the wearables, the ability to ship a patient a box of gizmos and manage them from their home, and really be able to do that seriously, all the way to this organization that I've been talking to, ships a crate and erects a head wall in your living room. And, first they have to come in and clean it before they can, to kind of create the level of environment. But there are technologies, and a lot of it has moved from, venture to incubator to startup in the course of the pandemic. And so I think there's been a boost of a lot of things. But the wearables, the sensors, and those kinds of things are going to create very different environments in the future.
Thanks. Andrew, and then Paul.
Just adding to the technology piece, I just think we also want to look at ways to connect the patient room space to family and caregivers, especially as we're limiting visitors, and how there's potential to kind of improve that condition, especially as we're looking at that loss of connection there. I think there's also some potential benefit if you think about people that may not have caregivers that live locally. This could be even outside of a pandemic situation. This could be an improvement to the quality of care by being able to connect to folks that are outside of the local situation. I also just wanted to add to the capacity thing. I think, obviously there's challenges with kind of these alternative care locations with staffing and supplies. So I think ways that we can find opportunities to add capacity within existing care environments is really important. So I know we had done some studies early on with some local hospitals, even in fairly new patient rooms that were fairly large, looking at if they could fit double capacity, and just the arrangement of the room didn't allow that setup. So if you can think of that from the beginning and really allow that arrangement to have double capacity in the event of a surge, it doesn't necessarily cost you any more space if the room is laid out correctly.
Okay, Paul?
Yeah, I think, Scott, you hit on a great point about staff being tired and burned out, right? And it's been a tough couple of years. And bringing that joy back in ways that are unique and different, and how that physical and digital world comes together can help. We have to switch from the current model, which is a clinician with a computer in between them and a patient to care for them, and blend that technology into the background. And there's a lot of new technology coming to the marketplace that's more ambient and allows that clinician to have that direct that in-person contact when they have to be in person, and enhances and brings that joy back to the clinicians' lives. And because the staff shortage is real and we can't have people leaving, we need to create that. As far as just tacking on to the creating surge space, one of the questions you asked us, John, last week was, what are the three things, right? Some low-hanging fruit stuff that we learned from the engineering side of the world, right? The way we design medical gas systems, the ones where we didn't take any diversity worked out well during this pandemic, and people were able to work seamlessly. The idea of that universal care room, but all of this, it allowed, you know, greater flexibility. But then all of this really comes down to greater planning around surge capacity up front, which was something that was really, it was there in design before, but now is more deliberate, and it's in the forefront of everybody's minds. Like those of us that have done this a long time, right? We remember Ebola and SARS and the other things that we've done to kind of, when a scare came up, react to. But creating those alternative care spaces in a way, not creating them, but having the infrastructure available in a planned way for your most likely scenarios is really of utmost importance. I'm at a hospital in Pennsylvania where I'm talking to you today, and they're surged into their atrium outside of their ED waiting room because their ED is beyond capacity still with Omicron surge. So, you know, and their comment to me when I walked in is they're saying, wow, wouldn't it have been great if, you know, when that building was designed 20 years ago, if we had thought to have utilities available right there to deal with this surge planning. So, you know, that surge planning can't stress the importance of it. You know, FGI did a fantastic job during the pandemic of, you know, creating the disaster preparedness guidelines to help walk clients through that. You know, I think it was a good byproduct of a lot of architects and engineers looking for ways to help. So anyway, just a few thoughts on the infrastructure side of the world.
Errol posted well, Errol, if you're there, perhaps you just want to say it rather than me reading it about translator services.
Thank you. So
Yeah.
you know, I wanted to overlay the discussion we're having about use of technology with the other discussion we're having, which is around where we work. And more of our staff now is working remotely with hybrid models, you know, 3 days at home, 2 days on the premises. And how do you take technology and allow them to expand their scope of work? And we found it to be very effective. I'll be curious to hear from other people. But one example, I know Ellen Maloney and Vin McDermott on the call, and what they did was they stood up video conferencing. So people from home are checking patients now into our screening programs using video conferencing. So they're not on site, they're virtual, and they've been able to continue to work in that capacity and do through some of the technological advances. And I think those hybrid models are here to stay. I'd be curious to hear how other people are interfacing those two discussions.
Anybody got a related story?
Well,
Pat?
this is
Yeah.
Pat, up at Dartmouth, we moved about 2,000 employees remotely within the first 2 weeks. I was just so overwhelmed by the IT effort that went into that, and how quickly and seamlessly it works. We've made the decision to keep about 2,000 of those employees permanently off-site, with some check-in space. We think we have up to 8 million in real estate opportunities with lease space that we can recapture. We've moved, in fact, I'm sitting in an office that's on the campus, but out of the main building. We are just capturing tons of space for clinical expansion with the opportunities to move non-essential services out of the hospital. Interestingly enough, we did our most recent employee engagement survey, and the highest scoring employees were those that were remote. We will be talking to our audit and compliance committee at the next March meeting about our efforts to get into compliance with now the 32 states that we have employees in terms of both labor law and tax law. So it's been a monumental effort by our HR, compliance, and IT folks. And again, the highest engaged employees are those that are remote.
I am highly engaged. What has been the experience of the other CEOs of recapturing support space for clinical use? That's kind of an interesting concept, and obviously it needs to be proximate, I would think, but perhaps there's offsite spaces too that can be repurposed.
So I'll give my 2 cents for BIDMC. This is Pete Healy, and I think we had similar experiences. I think, we had talked about having a better remote work program for years before the pandemic. We had also, in the same way as we had talked about having more effective telehealth. And, I think both were silver linings of the pandemic, with the, necessity being the mother of invention, and also a lot of kind of rules and regs set aside for the emergency. We were able to quickly do that. I think we need to then, like lots of things, get back to the kind of the right equilibrium there. So there were some folks who were offsite just, by necessity and safety for the first surge that do need to come back in some fashion. So I think we're finding that, and hopefully we will continue to get reimbursed for telehealth so that we can find the appropriate equilibrium on that. I think that, kind of general observation I would make about our experience in the pandemic is, to me, 3 different surges with, they were each different in their own way. And I think the first surge was all about facilities, capital, PPE, figuring out how to safely manage the virus and the patients and our staff. This most recent surge was much less about that and really all about staffing. We had figured out how to take care of these patients in a variety of areas, and I'm sure we could do it in garages and rooftops, but you have to have staff. And that's been the real challenge. So I've kind of thought of, if I put it on a chart and had one axis be capital, facilities, PPE, equipment, ventilators, and then have staffing kind of on the other axis. The first surge, we had lots of staff and frankly, not that many patients because we had shut down to everything but COVID, and we were all focused on the facilities issues. This last surge, we had tons of patients, lots of non-COVID and COVID patients, and not enough staff. And that became the priority. As this moves into an endemic, I think it's just continued strong infection control practices, vaccines, testing, and then preparing for another outbreak of virus someday, with all of the great ideas that you've thrown out there in terms of having really great facilities for day-to-day use, but facilities that can be quickly converted for emergency use.
Thanks, Pete. Those are good insights. One of the, I guess, the ways that we've adjusted to the nursing shortage is deputizing PAs and a bunch of other folks to step deeper into the nursing environment or the care environment. And I'd be interested to your perspective on whether that is likely to stay. And I mean, I know there's a whole bunch of regulatory stuff around that, but as an idea, is that the direction we need to be moving in?
Yeah, I have a feeling that we're going to go through a bit of a transformation of the healthcare workforce again, out of necessity, because as much as the COVID-19 patient and staff impact is going to clear, looks like it's clearing rapidly right now, this staffing crisis is going to take years to dig out of. So I think we will need to look at different ways of how the work gets done and how the team functions and members of the team and what they can do. It is a team sport. We all know that, and we can have new team players, and we can have different team roles. So I think there's going to be a necessary work that happens there. I was on Governor Baker had put together a healthcare workforce task force that I was invited to be on before the pandemic. And we had gone through and looked at a lot of issues. And at that time, the projection of what the healthcare workforce was going to look like was pretty dire. And so we came up with a bunch of recommendations, which included things like lowering the barrier to entry for certain roles, getting some of the regulatory stuff out of there so we could get more people to get involved, bringing in more people from underrepresented communities that would like the opportunity, but there's too many barriers. So things like that. And that was all before the pandemic. And then we had the great, retirement. So it's, I think it's going to be out of necessity. We're going to have to look at this. And at the end of the day, maybe it's a healthy thing. Maybe it's a healthy thing that we do redefine some of these roles so that we can have people really function at the top of their license, which we've been talking about for years and doesn't really happen.
Any other thoughts from our clinical leaders about that? Yeah, Rick?
Yeah, following up on what Pete said, I can imagine a model where on an inpatient unit, you have fewer nurses because there aren't any, and more CAs if we pay them more. And to have the way the work is done be different. Probably not as satisfying for the nurses, but because like doctors, they like face-to-face contact, but I think out of necessity that might need to change. And then also following up on Pete about the differences between the surges, it's surge number one, patient comes in the ER, you say, I don't know what the heck this is, but it's not good, this COVID thing. I wish we had a vaccine for it. I wish we had medications we could treat with. We better intubate him early before he gets bad. Surge number three, patient comes in. Okay, let's start the remdesivir and the dexamethasone, prone the patient, and whatever you do, don't intubate the patient right away. I mean, and thank goodness he's vaccinated. I mean, if you think about prior times in history, without going back to 1918, 1919, Spanish flu, the ability to have that kind of rapid development of technology is amazing. And I'm sure 10 years from now, we'll think that we were the Pony Express for coming up with things.
Mm-hmm. This sort of related to technology. If you look at where what programs kids are going into college to study, it's a huge increase of kids are studying computer science and related subjects to that, partly because of the salaries that are being offered in those fields. But what it suggests is that there's going to be a huge, over the next 10 years, there's just going to be a huge number of kids who are looking for jobs, who have technology, deep technology backgrounds. And so it seems inevitable that knowledge is going to be applied in different ways to the delivery of care in the healthcare setting. And we've already touched a little bit on some of those. I mean, obviously telemedicine is an obvious one, but applications, whether it's being able to regular video conference between a patient and family, these are all things that we're doing now. But I think the healthcare at home is obviously very technology dependent for it to be effective. So, I don't think we're going to necessarily have care robots roaming around, but it seems that there are probably activities that we are doing manually today that could be replaced by technology in some ways. And so sort of getting back to the point Peter was making, that folks are operating at the top of their license, and with some of the review of exactly what it is safe for patients, or excuse me, for some of these non-nursing folks, what roles are appropriate and safe for them to play in the hospital, that there will be a broader coverage of patients by non-clinical, I call them non-clinical because they don't have a nursing license, folks. And I know that brings with it a lot of other challenges, but it seems like the only way we're probably going to be able to get through here, given the numbers of nursing folks who are retiring and the baby boomer elderly wave coming through and the demands on the healthcare system over the next couple of decades. Scott?
Well, I was just going to, John, I was just going to add to that. And, when Paul talked about kind of, thinking back to SARS and Ebola, and when we had more kind of we had more planning for surges and so forth. I think in the 10 years or so in between, we did lean the hospital too much, and we kind of painted ourselves in a corner, right? That we didn't have that capacity. And there is almost an analogy with the staffing and the sort of how we think about the human dynamic here for caregivers that is the same. I mean, the medical schools that we've been working in, went through the big kind of, Flexner 2.0 back in the early 00s, and they all changed curriculum and doctors began to learn in teams and so forth. But there's been another wave that's come through medical education on interdisciplinary training. And so the nurses, the pharmacists, the social workers, they're all learning in teams together. And that sort of can enable, and they're using, the simulation and the other sorts of tools and AI to be able to sort of predict and come out of school working in teams. And so, that gives me some hope that we're going to be able to be more flexible in our human resource model, that if we have an exterior or an external force that robs us of a particular license at a particular moment, that we've got a team that's able to potentially fill in some of that.
All right, I love talking about the future, but let's get back to the present. How was food provided to patients, COVID patients? Right? Were you delivering right into the room? Were you monitoring? Did you have monitoring equipment around the bedside, or did you figure out how to put it out in the hallway and monitor through an opening in the wall so that to limit staff exposure to COVID patients, which I don't know if we were doing it around here, but I know they did it in some hospitals because they had the ability to do that. Interested on any thoughts about sort of staff COVID patient contact and all the challenges associated with that.
So I think here we had, it was a kind of a thoughtful strategy around how to go into the rooms for COVID positive patients as infrequently as possible and as often as necessary. So a lot of kind of planning around, okay, we're going to go in the room, we're going to go in as a group, we're going to do X, Y, and Z, the things that need to be done. We're going to do them as kind of quickly and efficiently as possible. And we're then going to exit the room. And then have, of course, the patient would have the ability to, to communicate with the staff. And, if they had issues kind of between those orchestrated visits, but that was seen as the best way to protect the patients and the staff. And so it was, I'd say from a clinical care standpoint and even a patient support standpoint, it wasn't optimal, it wasn't ideal, but especially in the early surge, I think it was viewed as necessary. And then use of iPads and other technology so for patients to maintain communications with staff and with family. Not having visitors is a real challenge. And, as speaking for myself, things have to get to an absolute last resort status before I'm supportive of that, because there's so many negative consequences that go along with it. But we did hit that a couple times, out of necessity. And these are not, it doesn't create for ideal care environments. It's safe and you try to do everything clinically appropriate, but it is, it's not ideal. In terms of food service, not that much change from a patient standpoint. Obviously, patients in the ICU, it's, less of an issue. A lot more changes related to staff and cafeteria and break rooms and visitor. But the patient food service, I didn't hear anything about that being kind of different than what it would have been normally, other than probably how they manage that with the patients.
I know at WellForce, specifically Tufts, we work really closely with infection prevention to make sure that we had the policies and procedures in place for our food service team. in the initial part of the pandemic when PPE was a real issue. We worked with nursing, and nursing, was donned and doffed, and they would take the trays into the room. As we've kind of evolved through the pandemic to this point, we've worked with environmental health and safety. We've gotten all of our food service tray passers fit tested and are going back to a normal kind of food service model, where our folks are going into the rooms and delivering trays and having that interaction with the patients. At Melrose, we had specific COVID units. And so the staff wouldn't even go on the unit. They would just literally pass through the wall and nursing would take the trays and pass them to the patients. And they were designated COVID units. So it was a little different feel than at Tufts, where we kept them in individual rooms.
Thanks, Michael. Rick, were you going to say something?
Yeah, following up on the staff part of it, I think it's important to make sure that you have enough space for them to eat with space in between, which usually means repurposing conference rooms as eating areas if necessary. Unfortunately, these pandemics usually occur at a time of year when you can't eat outside very well. So it is limiting. The other thing is for visitors and vendors, preferably to not use the cafeteria, keep that for staff. We, of course, eliminated visitors for long periods, but you still had some, for essential support of particular patients. But I think that was helpful.
We're getting close to the hour. If folks have questions who are listening in, please put them in the chat. I haven't been checking the chat. Teresa, are there any questions in there?
So while we're waiting,
I think we've been covering them as we've gone through. So
Okay.
if people want to keep adding, then I'll bring them up.
Okay.
John, can I
Yeah,
add
go
one
ahead.
quick comment, something we haven't touched on basically, which is especially during the third wave, we've seen, unprecedented, I would call uncivility and violence towards staff, and unprofessional behavior, which has really put enormous stress on the staff. And so as we think going forward, and we're designing the new hospitals for the next 50 years, think about security. Are there ways we can design to help decompress situations, avoid escalating these situations, and then think of the security of the staff, because it's been quite a problem, especially in the third wave.
Yeah, that's a challenge, right? So other than having security folks, a lot more security folks, but even then they're not necessarily in the place where this is happening. If it's happening in the inpatient environments, it's a little difficult to deal with.
Yeah, but I would say, Wynn brought up the issue earlier about patient well-being and the environment is such a difference in terms of bringing joy back to the workforce. And I do think in the same way as design can help us think about touchdown space or decompression space, I think the way we design hospitals can also mitigate some of the risks to the staff when it comes to violence. So just to have all those creative minds thinking about how to design to try and mitigate some of these risks.
So Sarah had a question. She wanted to know, are there investments that you've made in flexibility in the past that did pay off or have not paid off? Sarah Markovitz.
I would just say that we have a 10-year-old patient tower. Actually, I guess you can't say tower. 10-year-old patient tower in Gardner, which I guess isn't a tower when you get to the city, but when it went all single rooms, someone did have the forethought to put double gases in the head walls. So we did end up having to cohort patients together and make them doubles, and we were set up for that, which was a nice plus to have. And even though they were singles, they were larger than our old doubles that we had replaced in another wing of the hospital. So it worked out well that we could take care of patients that way. So that was, and you think about it every time you go build, how are you going to design to save money, to value engineer? I hate that word. And those are some of the things that are easily eliminated as you go through a process. And luckily, like that stuck, and that saved us from having hallway beds. But it was the old school rooming together.
So another question came in from Liz Norman, and she said it was mentioned temporary deregulation in pandemic help hospitals adapt more quickly. Aside from time savings, are there any ways that hospitals were able to innovate to provide patient care that AHJs might not typically allow, or might move forward now that things are calming down a bit?
It's interesting on that one, Teresa. I've been working with some health systems in places like Singapore, where there is more of a kind of a tradition of tropical disease, and so the fever tent and how you how you manage infectious disease is kind of more embedded in their psyche in the tropics. And essentially there's a mindset that the surge the surge overrules the AHJ, and whether it's doing things in a temporary structure, whether it's commandeering public space, whatever, that the public health mandate kind of overrules the AHJ, and they kind of suspend it on a temporary basis. And so I haven't seen any of that, of course, in the Commonwealth, where the AHJs are willing to suspend things. But I think that is ultimately in a crisis, it's what you have to do.
I'm wondering if moving forward that they've seen some of the things in action, and they're more likely to be open-minded about adding new things or revisiting what worked that might not necessarily have been accepted prior.
I think it also goes back to kind of the pre-planning, if we can have these plans in place so that I think a lot of us on this call probably spent a lot of time in the first couple of months of the pandemic coming up with plans for surge and how to deal with these things, and getting reviews in front of the AHJs. And I think if those plans can be in place and it already pre-reviewed, I think that'll obviously help the responsiveness and making sure that it's really safe.
We're 5 minutes to the hour. I think this is a good time to break and give everybody a couple of minutes to stand up and walk around their desk. It's been a great discussion. I want to thank our panelists for your insights. They've been very helpful. And, I hope we're not back talking about the fourth wave anytime soon, but I'm sure there'll be something else coming down the pike, right? That's probably a given. So thanks for everybody who joined. This has been recorded, and Teresa will be sending out a link sometime in the next week or 10 days or so, I guess. And we look forward to the next session, which will be in a couple of months. So have a great day, everybody. Thank you.
Thank you, John.
Thank you, John.
Thank you very much.
Thanks, Sean.
Thank you,
Thank
John.
you.
Great job.
Great as usual.